So let's enter into the topic. See there. International Menopause Society defines menopause. This is a natural menopause as the permanent cessation of menstruation resulting from the loss of ovarian follicular activity. So this is a permanent cessation of menstruation. Now, if you remember, whenever a baby, a girl baby or a female baby is born, already there are ovarian follicles present in the gonad. Now, those ovarian follicles are in limited number, right? So every month, one of them is chosen. Okay, after puberty, of course, after menarche has occurred, one of them is chosen, and then it will develop into the Graafian follicle. Then there is ovulation in a normal, point. In abnormality, there is no ovulation. There is no selection like that. Okay, that's a different thing. I'm talking about the normal physiology now. So that is happening. But the life of those ovarian follicles are limited, and when age of menopause is reached, okay, those ovarian follicles, they they become older. They are not anymore available. Okay, so their activity ceases, their activity fails, then menopause occurs. This is the basic understanding here. Natural menopause is recognized to have occurred after 12 consecutive months of amenorrhea for which there is no other obvious pathological or physiological cause. Okay, number one, the age matters. It should occur uh, after the age of 45. Let's talk about the average one here. Okay, after the age of 45. Sometimes it may come a little bit earlier in some of the ladies, or sometimes it may come a bit late also. It may come late. Like, see here, on average, it occurs at 51 years, although it can vary between 40 and 58 years of age. Now, this 51 years, average age is taken from the United Kingdom or British population. So in Asian population, okay, it may be different. A good study is necessary for that. Okay, it doesn't matter to us. What we should know is the reproductive age group means 15 to 45. That is acceptable all over the world. After the age of 45, menopause can occur anytime. Okay, just remember that much. In some of the lady, it may occur at 48 years of age, another 50, 51, and even till 58 years of age. Okay, that 58 is very, very, late actually. If menopause occurs before the age of 40, it is considered premature. Okay, premature menopause. So what is the point here? 12 consecutive months of amenorrhea, okay, and after that, no more menstruation. This is called menopause. See, the permanent cessation of menstruation. Now, let's move further. What is the etiopathogenesis of menopause? The menopause occurs when the supply of responsive oocyte is exhausted. That's what I told you just now. Okay, the oocyte which are present inside the ovary, okay, they are no more there. They are not responding anymore. They become quite old. So that is the reason. The perimenopause is characterized by an increased proportion of anovulatory cycle. This is around the period of menopause, perimenopausal period. As a result, progesterone production is decreased. Secretory endometrium changes are less marked and menses become irregular. So before the natural menopause occur, she is already showing some sign and symptom of irregular bleeding. And this is because of the hormonal imbalance. Okay? Many of them will develop an ovulatory cycle. Without ovulation, there is no progesterone. Without progesterone, the, the, the secretory changes in the endometrium cannot occur. Okay, and that can result in irregular type of period. After the menopause, see there, after the menopause, estrogen production drastically falls because the most important estrogen in the reproductive age is estradiol, which is produced by the granulosa cell of the developing follicle. Now that production of estradiol is no more there, it is lost. Okay, thus the negative feedback on pituitary production of FSH and LH, okay, by uh, estrogen is reduced. So serum levels of FSH and LH rise, and values greater than 40 international unit per liter indicates the postmenopausal status. So this is the point which we just discussed, okay, in some other topic. So this is a important knowledge here. Estradiol fails to produce. Without estradiol, the negative feedback mechanism doesn't exist, and FSH and LH are produced by anterior pituitary, so they keep on coming there, resulting in excessive level. Let's move on. Now, see there. Now, okay, so let's talk something more. What are the clinical features of menopause? We should know about this, because uh, if some lady becomes irritable, some lady can become depressed, some may develop some flushes, we call that hot flushes and things like that around that age. If we do not know about this type of clinical feature, we fail to diagnose it. Okay, so that's why these symptoms are important to understand. See there. Now, the common menopausal symptoms, okay, which occur in 2/3 of the women, are around 10 to 20% describe these symptoms as distressing, and the duration and the severity of the symptom vary and cannot be predicted. So one lady cannot be compared with the other. That's the point here. Different types of women can present with the different types of symptoms, and duration of the symptoms also varies. Now, the effect of the menopause may be discussed in the following type of symptoms: vasomotor symptom, psychological effect, urogenital disease or symptom, you can say, or disorders, cardiovascular disease or disorders, osteoporosis, and breast problem or diseases. So we are going to talk about one after other. Now let me make quite clear about these things. Because of the menopause, these different types of symptoms and signs will appear in the woman. So what are these? Let's talk about them. Now, what are the vasomotor symptoms? This is very common. Hot flush, okay? Hot flush is one of the most important one. This is known as hot flushes. Is an uncomfortable and subjective feeling of warmth in the upper part of the body. So she complains, I'm feeling very hot. So are you also feeling hot? She may ask to other family member, but they are fine. They are not having that type of symptom, So we have to understand this is one of the very important symptoms of perimenopausal age. It may be accompanied by nausea and sweating that can be profuse and followed by a chill or palpitation, and are particularly troublesome at night, interfering with sleep. And because of this, she may be anxious, or sometimes she may be depressed also. If we do not, explain the problem to her, then she may be thinking, I'm having some other organic disorder inside me. I was not having this problem before. Why I'm developing this? This type of thinking should come or will come in her mind. But actually, these are all physiological things. This is occurring because of the menopause. The menopausal flushes are of hypothalamic origin, which are associated with the pulsatile release of GnRH. Pulsatile release of GnRH. So these are hypothalamic origin. One hypothesis is that flushes involve episodic pulses of dopamine and GnRH together with a down setting of the central thermoregulatory center. Okay. So you don't need to know in detail about this, just to know that there is a pulsatile release of GnRH, which are associated with the menopausal flushes. Now, what are the urogenital features now? Urogenital features. See there? Now, the vagina, urethra, and bladder trigone are estrogen dependent and gradually atrophy after the menopause. Now, what do you mean by trigone of the urinary bladder? Where is this present? Anyone? Where?
Sir, it's the opening of the two urethra and two ureters and the urethra, sir. It's called trigone.
Excellent. Excellent. Very good. So this is present on the posterior wall of the urinary bladder. Is absolutely correct. Trigone means is a triangle shaped structure where two ureter are open and one urethra is open, exactly in the three corner of the triangle. Trigone. In case of female, this trigone is also estrogen dependent. Means if estrogen is no more there, then all these will undergo atrophy. They'll undergo atrophy. So absence of the estrogen results in thinning of the vaginal mucosa, atrophy of the vagina, which may cause severe superficial dyspareunia and bleeding. Now, there is painful sexual intercourse because of this atrophic vaginitis or atrophic vagina. Okay, so because of this painful sexual intercourse, many couples may avoid sexual intercourse as a result of the discomfort, and it may result in bleeding as well. Now, at the same time, there is lack of the glycogen because the deposition of glycogen in this vaginal mucosa is dependent on the estrogen. So, if there is a lack of glycogen, okay, it results in, okay, infection. So there is an increased risk of infection, and this is a mechanism for that. It results in rise in vaginal pH, means the pH will become alkaline. Alkaline, usually it is acidic. This glycogen will be converted into, lactic acid. Okay, lactic acid by those commensal organisms. Uh, can you name which are those commensal organisms present in the vagina? What are the important bacteria there?
Lactobacillus. Sir, lactobacillus.
Lactobacillus, yes, sir.
Very good, excellent. These are lactobacilli, also known as Doderlein bacilli, but lactobacilli are the preferred term. So they can convert into lactic acid. And because of the lactic acid there, the acidic pH is there. That acidic pH is protective for the vaginal mucosa. It doesn't allow easy infection to occur. But after that, like glycogen is lacking, then the pH will be alkaline, and there is an increased chance of infection now. There is a reduced elasticity of the urinary bladder, which produces frequency and urgency of the micturition. There may also be nocturia and dysuria. So these are some other features which results from the urinary bladder. Let's move on. You see there? Some other features of urogenital, symptoms are vaginal bleeding after the menopause can occur because of the atrophic vaginitis. Remember that atrophic vaginitis is the most common cause of postmenopausal bleeding. But let me repeat that sentence again for you. Postmenopausal bleeding should be taken very seriously until and unless you confirm this, that there is no endometrial cancer. Endometrial cancer is not the commonest cause of postmenopausal bleeding, but it is the most important one. So we must always rule it out. Now, what are the cardiovascular, symptoms of menopause, or what are the cardiovascular problem of menopause? From a cardiovascular standpoint, the protective benefits of estrogen on the lipid profile, that is, increase high density lipoprotein and decrease low density lipoprotein, as well as the effect of the estrogen on the vascular endothelium. Okay, all are gone because estrogen is very, very reduced after the menopause. And that estrogen, which was present during the, uh, Reproductive age is preventing from atherosclerosis or atherogenesis. Okay, it also increases vasodilation, and it is inhibiting platelet aggregation or adherence. All of these are very important effect related to the coronary artery disease. Remember, atherosclerosis is the most common cause of coronary artery disease in 90% of the time. Only in 10% some other causes are responsible, like vasculitis, like thrombosis. Okay, some other points are there, but atherosclerosis is the most important one. So what is the effect of estrogen regarding atherosclerosis now? It is preventing that. That's why we always say that whenever a lady is menstruating, during that time, she is well protected from coronary artery disease or even the stroke. But remember, not completely, okay? 10% chance is still there, because that 10% chance is by some other problem, not by atherosclerosis. So don't be surprised if a lady develops MI at a reproductive age, or she develops stroke during that time. It is, though it is uncommon, it can be seen. In medicine, we always talk about common things first. That's why we are discussing like it here. But after the menopause, the risk is equal, like the male, the same risk. Okay, and she may develop MI now, she may develop stroke, or she may develop peripheral vascular disease. Let's move on. Now, what are the psychological symptoms, after menopause or in a perimenopausal age? A wide variety of psychological symptoms are noted in menopausal women, and they include irritability, confusion, and lethargy. There may be memory loss, there is loss of libido, or even depression. Now, see there. These all things are occurring because of the hormonal change in her body. Okay, during that time, okay, the lady may be irritable, she's quite confused. Some of them may become lethargic, some of them may become depressed. Okay, there is no desire for sexual intercourse, and if they gone for that, then there will be severe pain or even bleeding because of the atrophic vaginitis and things like that. So we should consider this symptom very seriously. We have to understand, the family members should understand, yes, she is going through all these changes. It is uncertain whether these are primary effects of the estrogen deficiency or simply manifestation of other processes. Insomnia, for example, is probably due to night sweating. So it is poorly understood, but we strongly believe because of some knowing or unknowing pathology or mechanism, these are related with the hormonal changes there. In general, a trial of hormone replacement therapy is indicated before prescribing specific psychological agents like antidepressant. Now, let me come to the practical thing here. Okay, so many of the doctors, so many. Now, what will happen in the clinical practice? Let me tell you that the lady is around 55 years of age, 55. So probably she has developed menopause just 1 or 2 years prior, or she's probably developed around 1 year prior. Let's talk like that. She's probably having all these features. Whenever the doctor asks a question, she may be having this feature. If she goes to some general physician, okay, who doesn't have much knowledge of gynecology, remember that, because they have spent a lot of time in managing those patients which belongs to internal medicine side. They may think about psychiatric illness here. They may think this lady is depressed, this lady is anxious, and they may prescribe some of the medicine. Now, can you tell me what are those anti-anxiety or anti-depression drugs? What are those?
Sir, drug like citalopram, sir, like escitalopram, sir, fluoxetine, sir, fluoxamine, sir, paroxetine, sir, sertraline, sir,
Excellent. All of the names are absolutely correct. Very good. So that's so many different, like benzodiazepine group of drugs are there. Okay, then all those SSRIs are there, all those a tricyclic antidepressant are there, TCA we call them. So any type of drugs the doctor can prescribe, but actually they are not thinking that these are because of the menopausal thing. So only treatment they need probably the hormone replacement therapy. Okay, a bit of estrogen containing drug is what they all needed. So it is not a good practice to label them they are depressed or they are anxious because of this thing. Okay, at least a trial of the hormone replacement therapy should be given. If that is not helping, then okay, we can give those anti-depression drug or anti-anxiety drug later on. Let's move on. Now, another type of clinical feature in case of post-menopausal woman is osteoporosis. Now, it is related to the bone. During and after the menopause, there is a marked tendency for women to lose bone material. The patient is at increased risk of bone fractures. Okay, bone fracture. Now, where those bone fractures occur? Now, see here, this is an important point. These bone fractures occur commonly in the vertebra. This is known as cross fracture or compression fracture of the vertebral body. And because of this, she may have back pain development. Okay, this is a pain on the lower back area. This is very common. The fracture may develop in the neck of the femur and even the distal forearm. Now, this neck of the femur is called like a femoral neck fracture. Now, let me discuss this in a way of a practical point of view. These are a little bit older women already. Okay, so whenever they are taking shower in the bathroom, or if the floor of the kitchen is wet, they may fall there, they may slip there, and with a small amount of fall, this is not a big type of fall, they're not falling from a height, there's a slip there on the floor, they may break the bone very easily. They may break the neck of the femur, and if neck of the femur is broken at this age, it is very difficult to treat. Mostly, we have to go for the surgical type of management. Treatment is a possibility, I'm not saying that, but it's difficult for that particular age. Another type of fracture which is very common is called Colles fracture. Okay, Colles fracture means distal forearm fracture. Colles fracture is a radial fracture. Okay, because that bone is also osteoporotic during that time. The time taken to reach the threshold of fracture depends on the peak bone mass and the rate of bone loss. If somebody is developed menopause quite early, for example, around the age of 40 or 42 or 43, by the time they become 55, already a long gap is there, isn't it? So they can fracture the bone mass easily. It also depends, in some other factor, what is their nutrition and things like that. What was their overall bone health before? But the process has started a bit before. In the decade immediately preceding the menopause, there is an annual rate of bone loss of about 0.3% of the bone mass per year. So even before the menopause started, the process of decreasing bone mass started. And after menopause, it becomes very rapid. What may be the basic mechanism there? Postmenopausal osteoporosis is thought to result from osteoclastic activity unbalanced by that of osteoblastic activity, as the latter have been shown to be directly stimulated by estrogen. So only osteoclastic activity is going on. This is not replaced by osteoblastic activity because there is no estrogen. Estrogen is stimulating the osteoblast for the synthesis of bone. Okay, only dissolving of the bone is going on, not synthesis of the bone. As a result of that, bone becomes weaker, and then there's a chance of different type of fracture. Let me repeat again, the most important area where the osteoporotic fracture occur in the postmenopausal woman is vertebra. Remember that, vertebra. another neck of the femur, okay, or distal end of the radius. And because the bone health is already weaker, the treatment is challenging during this time. Okay, with this information, let me stop here. We'll continue next time. Okay, thank you guys.
S-
Thank you, sir.
Sir, I have a
Thank
question,
you.
sir.
Yeah, sure. Yes.
Sir, what if the women take like supplements for the like calcium and vitamin D and stuff like that? Will it recover the bone loss or not?
Yeah, that's a very good question you have asked. Very good. It helps them, it helps them. It may not completely, uh, reverse the process of osteoporosis, but it somehow delays that. For example, it all depends. If the availability of calcium is good, if the availability of phosphate is good, then that osteoblastic activity may resume again. But without the estrogen stimulation, it is never complete. But along with them, if we replace a bit of hormone, estrogen, and calcium, okay, a containing drug or vitamin D, then it really helps them, because everything which is lacking we are providing there, isn't it? So it may help them. Okay. And one common practice in a postmenopausal woman, we routinely give them calcium supplementation and vitamin D supplementation. At least some of the benefit they will get from those medicine. Now let's move further. Another type of problem occurs on the breast. Now see there, after menopause, the risk of breast cancer increases with age, but the rate of increase slows after the menopause, because breast cancer is about the estrogen stimulation, and after the menopause, that estrogen stimulation is not there. A woman who has a menopause in her late 50 has twice the risk of developing breast cancer as one whose menopause occurred in her early 40. It clearly tells you. Now, somebody developing menopause at the late age, so there is increased estrogen stimulation because she is producing estrogen for a longer time than whose menopause occurred in her early 40s. Now, she has already stopped producing estrogen, you know, some time ago. Okay, she has already stopped. So the risk is also decreased regarding the breast cancer development. Now, all of you, please focus on this, picture here or on this slide. Now, this is a good one, and this is, containing the things which we have discussed till now. See here, hot flushes or flashes, whatever you want to say, insomnia and depression. Okay, these are one type of problem. Osteoporosis is another. Atherosclerosis is another one. Then all these, atrophic changes in the female genital tract are other one. A breast, okay, also will become a bit atrophied after menopause. But the more important point is regarding the, decreased risk of breast cancer. It depends when the lady is having menopause, though. Atrophic vaginitis is another problem. Now, all of these are caused by ovarian failure. See this? The function of the ovary fails. So there is no gonadal estrogen there. And because of this, there is no negative feedback given to the hypothalamus or anterior pituitary. And as a result of this, there is increased FSH and LH. Increased FSH and LH. This is very, very easy to understand. Increased FSH and LH, increased norepinephrine, increased dopamine, and increased prostaglandins are doing all the things there. Okay. Now, let's talk about the management part. We have understood what is going on in our body. So, how to manage it? The first thing is hormone replacement therapy. Everything is occurring there because of lack of estrogen hormone. So, why don't we supply that? That is known as hormone replacement therapy. See there. Despite the controversies surrounding the risk and benefit, hormone replacement therapy is the mainstay of treatment here. Hormone replacement therapy aims to replace estrogen in the postmenopausal woman and so reverse the adverse effect of estrogen lack. Very clear-cut mechanism. There is no estrogen after menopause, so we are replacing it from outside. The key indication for the use of hormone replacement therapy, HRT, is to relieve the troublesome vasomotor symptom like hot flushes, okay, associated with menopause, and to improve the quality of life. These are the important objectives. The aims, therefore, are quite different to those of contraception, for which a high dose artificial steroid are used in order to suppress the ovulation. In this case, we give some natural steroid and in lower doses. Now, one small question for you. What is the most important form of estrogen produced by reproductive age group female? What is the name of that
Sir,
estrogen?
Estradiol.
Estradiol. Estradiol and reproductive, and on menopause, estradiol.
Okay, so estradiol, very good. Estradiol is the most important or most active type of estrogen which is secreted by the reproductive age group female. Absolutely correct. Now, is there any estrogen present after menopause or not?
There may be
Yes?
a small amount of estradiol.
Estriol, very small amount of estriol is formed. How? From where? Which source it is formed? Yes, that's the question. From which source? Because ovary has failed. So which source?
Sir, it is produced by the peripheral aromatization in the adipose tissue and the muscles.
Exactly. Okay. Now let me repeat that again. He's absolutely right. Remember the synthesis of estrogen inside the ovarian follicle. Okay. It is done by the granulosa cell, and in the beginning it is always androgen, which is synthesized by theca cell. That in androgen will be converted into estrogen by aromatase enzyme. The same type of mechanism can occur outside the ovary in the fatty tissue or in the lipid. There also aromatase enzyme is present, and remember, androgen is continuously being produced by adrenal gland. Okay, adrenal gland is there, adrenal gland is functioning, and there are three layers of the adrenal cortex. One of the layer is secreting androgen. That androgen may be converted into estrogen by aromatase enzyme in case of fat, okay, in case of fatty tissue or inside the fatty tissue. So a bit of estrogen is still present in them, but that may not be enough to reverse all the effect of these postmenopausal changes. Let's move on. Now, hormone replacement therapy depends on the following factors. See here, whether or not she has had a hysterectomy. Now, so many women at that age may have undergone hysterectomy in the past because of some indication. The menopausal status, it depends on the menopausal status again. It depends on the past medical history and current medication. Okay. Now, whether or not she has had a hysterectomy, in women who still have their uterus, a progesterone must be included to avert the consequences of prolonged exposure to unopposed estrogen. And women who have had a hysterectomy, they are offered estrogen-only therapy. Very important concept here, because if uterus is there and if we only give estrogen, remember, this is just like an unopposed estrogen, and prolonged unopposed estrogen is a risk factor of which disease? Yes, it is a risk factor of which condition?
Endometrial carcinoma, sir.
Endometrial carcinoma, sir.
Exactly. Endometrial carcinoma, so which we don't want to develop in that lady. Okay, that's why you have to mix progesterone with estrogen if uterus is still there. Very easy to understand. But in those lady who don't have any uterus there, where hysterectomy is already done, now there is no real danger of endometrial cancer development, uterus is not there, so we can offer estrogen-only therapy. Now, regarding the menopausal status, perimenopausal women should be offered sequential therapy using daily estrogen and cyclical progesterone is one, while postmenopausal women can be offered continuous combined therapy using daily estrogen and daily progesterone. Now, it is all about whether they are still menstruating or not. Now, perimenopausal women, probably they are still menstruating, so cyclical progesterone is enough. Okay, hormones are already less in them, but remember, there is no complete stoppage of a menstruation. So you are doing almost like the natural things are happening in our body. In the second half of the cycle, only progesterone is secreted and estrogen is throughout. So we are maintaining the same thing here. Whereas after the menopause, okay, so we need to supply continuous combined therapy, that is estrogen and progesterone every day, because we don't want to mimic the same cycle again. Okay, this is another point. It also depends on the past medical history and current medication. We always do that in the clinical practice. We want to see whether it is contraindicated or not. Okay, if there is some thrombotic type of disease, isn't it? If there are some other gynecological problem associated with some malignancy, something like that, then probably this type of therapy are contraindicated, and current medication is always asked. Now, some other management are lifestyle measures. Now, evidence suggests that regular sustained aerobic type of exercise, such as swimming or running, improve several common menopause related symptoms. So they should not be, housebound. They should go outside. They should do some stretching exercise on their body and some other physical activity as well. Avoidance or reduction of alcohol and caffeine intake may help to reduce the severity and frequency of vasomotor symptom. Now, alcohol consumption is never good. Okay, don't go after the controversy. Some of the study may say red wine is good for the cardiovascular system and things like that. Yes, it may be good, but in front of your patient, you don't talk like that. Patient will twist your suggestion, your advice, and they think, yes, my doctor has told me to drink, no problem, and they will tell that to the family member if the family members are not there. Okay, so advice or suggestion should be given accordingly. Okay, I'm not saying we tell the lies to them. We are still telling the truth, and it is the truth. Alcohol doesn't have any beneficial effect, so avoid it, especially at this time. That lady must avoid. And caffeine. Now, caffeine is a type of compound which is present mainly in coffee, tea, and even green tea, or even in some beverage. Even Coca-Cola, those type of beverage or drinks having a slight amount of caffeine. So excessive consumption of caffeine is not good. But if there is a habit of consumption, probably 1 to 2 cups of coffee or 1 to 2 cups of tea would be fine, no problem. Regarding diet and supplement, see here, supplementation of calcium, calcitonin, and vitamin D supplementation, okay, are important for the prevention of osteoporosis. Rather than osteoporosis, we want to use the term osteomalacia here. We don't want bone to be weaker because of osteomalacia at the same time. Okay. Now, this calcitonin, what is the role of calcitonin here?
Decreasing of calcium by antagonizes the PTH.
Yes.
Excellent. Very good. He is answering in a very precise way. Calcitonin's function is exactly opposite to the PTH. Exactly opposite. If PTH is increasing the calcium level in the blood, calcitonin will decrease it. If PTH is eroding the bone, okay, or it is doing resorption of the bone, calcitonin will go there and deposit the bone. So we want this type of drugs here. Now let's move on. Now, what are the pharmacological alternatives we have? Okay, from hormone replacement therapy. They are progesterone or progesterone, clonidine, and beta blocker. Now, progesterone are the popular alternative to combine hormone replacement therapy in women with intractable vasomotor symptom and contraindication to estrogen, like breast and uterine cancer or venous thromboembolism. Just now I told you. Now that's why history taking is so important one. Good physical examination is important. Who knows? The lady may be a cancer patient, breast and uterine cancer, or she is having thromboembolic disease or thrombotic problem. During that situation, estrogen is contraindicated. Okay, estrogen is contraindicated. So we have to give progesterone only. That is the meaning. Megestrol acetate is a form of progesterone which are shown to reduce the hot flushes by almost 85%. So it is one of the effective alternatives. Clonidine has been shown to reduce the hot flushes, but we really do not know what's the mechanism there. Okay, what type of drug is clonidine? It is used for which purpose?
Antihypertensive drug.
It's
Alpha
alpha
2 adrenergic agonist.
Exactly. This is an antihypertensive drug. Very good. It is one of the antihypertensive drug, and it is called centrally acting antihypertensive drug, and it acts on the alpha 2 receptors which are present inside the CNS. Alpha 2 receptors, and remember, it doesn't block them, it stimulates them. That's why it is known as alpha 2 agonist drug. Okay, this is the important point here, and because of this, it is one of the favorite question of the examiner as well. But you already know that. Excellent. It is often used as a first line treatment in a dose of 2 to 3, 25 microgram tablets twice daily. Just know clonidine is one of the options. That's it. And beta blockers are used for the relief of palpitation and tachycardia, which are common along with hot flushes. Beta blocker. Okay. We can use the cardioselective beta blocker or even the non-selective one. Now, some other pharmacological alternatives we have, or we can use, there are selective serotonin reuptake inhibitor, which we call it SSRI, selective serotonin reuptake inhibitors, or selective noradrenaline reuptake inhibitors. Now see that selective noradrenaline reuptake inhibitor, venlafaxine is one of the example we have. Okay, venlafaxine, and SSRI is fluoxetine and paroxetine. These are the example. So just know the name, not much information here, because they can be used to reduce the flushing symptom or hot flushes. And look at the efficacy, almost 50% in case of paroxetine use, while fluoxetine has also been reported to reduce in 60% of the cases. Gabapentin is another drug which can be used here. Now tell me where gabapentin is used commonly rather than here.
Anticonvulsant medication.
Anti-seizure, sir.
Yes, anticonvulsant or anti-seizure medicine. This is a newer type of anticonvulsant drug, not a conventional drug. We call them newer type of drug. And this drug is also used if somebody is having chronic pain symptom. Chronic pain symptom. Okay, in that condition also gabapentin can be used. Excellent. So it has shown efficacy for hot flushes reduction, a 45% reduction in hot flush frequency, and 54% reduction in the symptom severity. So it may be beneficial. Let's move on. Now what else? Postmenopausal vaginal symptom are best treated with locally delivered low dose of natural estrogen in the form of tablet, ring, cream, or even pessary. So these are the different way of delivering of the estrogen in the vagina. And remember, in case of postmenopausal woman, the vagina will be atrophy, okay, because the vaginal mucosa is responding to estrogen, and it can lead to atrophic vaginitis, and sexual intercourse and things like that are very painful there. That's why to decrease those symptoms, we may try this natural estrogen in the different form. Okay, that is the purpose. Now, psychological support is an important part of the management during that time, and this psychological support is provided by husband, okay, sons and daughters, as well as other family member. Okay, this is a very important one. The market placebo effect in several studies point to the value of psychological support and a sympathetic ear. Okay, we should listen to our problem. That is the meaning of sympathetic ear, and we should give her different types of moral boosting advices. You should say this happens to everyone, not only with you, okay, and it will disappear along with time, and there are certain things which will decrease it. Okay, all these things will really help her. The menopause frequently coincide with other stresses such as children leaving home, which may exacerbate the biological changes associated with this time of life. Now, let me clarify this. This is very important one. In Nepal, okay, I'm not sure about Pakistan and other countries what is the situation, but in Nepal these days, many of the children, okay, after they are grown up, for example, like me, I'm one of the example here. They don't stay with their parents. Okay, they don't stay with their parents. They are going to some other places. Okay, maybe abroad, maybe some other cities inside their own country, or even in the same city. They do not stay with their parents. They stay in some other home. Now, like, what is the effect of this to that lady during this emotional crisis time? It will really aggravate the situation. She may overthink. Oh, my sons, my daughter are not with me at this moment, and if they are here with me, that really boosts my confidence, like that. So it is just exacerbating the situation. So the psychiatrist or the doctor who is taking history should consider these things as well. Okay, and just talking like that may help her. You don't need to do anything. Okay, so we should give that confidence in her. Now at the end, let's talk a little bit about hormone replacement therapy. Okay. What are the different things we give here? What are the benefit? What are the complications of hormone replacement therapy? Okay, and things like that. Now, what are the preparation and regime of hormone replacement therapy? Hormone replacement preparations consist of daily estrogen and with either sequential or daily progesterone if necessary. Now, those different situations I already told you. If the lady, already undergone hysterectomy, daily estrogen is enough. If the lady still has uterus inside her, okay, but she is in the perimenopausal age, then daily estrogen with sequential or cyclical progesterone is necessary. Whereas if she already developed menopause, then everyday estrogen and everyday progesterone is given. So these are the different preparation. Estrogen, okay, estradiol, okay, estradiol 17, beta estrone or conjugated equine estrogen. See that the different forms are there. Can be administered orally, intravaginally, or transdermally. Okay, that the different route of administration: orally, intravaginally, or transdermally. Estradiol is very commonly used here. Progesterone can be oral, transdermal, or delivered via an intrauterine device also. This is known as IUCD, intrauterine device, or contraceptive device. Though the principle of drug is not contraception. Okay, the contraception is already naturally done there, isn't it? There is no more ovulation now. That's why we only call it IUD in this case. Now, consider hormone replacement therapy in the following patient: perimenopausal or recently postmenopausal symptomatic woman in whom risk factors for cardiovascular and thromboembolic disease are low. So in them, we use or consider hormone replacement therapy. There should be symptomatic first. There should be certain indication, isn't it? And at the same time, the risk factor for cardiovascular and thromboembolic disease are low. Like there is no real risk factors for thrombosis in her, because estrogen will increase the chance of thrombosis. Who are at high risk of fracture if there are no contraindication, then also hormone replacement therapy are used, because lack of estrogen is causing osteoporosis and there is a high risk of fracture, and hormone replacement therapy will prevent from that. Note, breast and cervical screening should be up to date, and any abnormal vaginal bleeding should be investigated, okay, before you start hormone replacement therapy, because here is estrogen. That estrogen may complicate the situation in this condition. These are the benefits of hormone replacement therapy. It is the most effective treatment for vasomotor symptom experienced by postmenopausal women. Like, in summary, these include: it arrests the flushing in 77% of the time. You don't need to remember the percentage here. Improves headache and insomnia. It reverses genital tract atrophy, which is one of the troublesome effects of lack of estrogen. It improves psychological symptom. Okay, that is, the overall confidence is improved in about 30%. That is a situation where there is lack of confidence. Okay, that is poor self-belief during that time because of all these hormonal imbalance and different type of changes going on in our body. So it really helps, and it reduces osteoporosis and thus fracture rate as well. So hormone replacement therapy has an important role to play in case of menopause or postmenopausal woman. Now let's talk about what are the side effects. Now these hormones have a lot of side effects as well. That's why, though they have certain advantages, many of the ladies don't want to go for the use of this hormone, because we have to explain the side effects. We have to tell the side effects of the drug to them, and it is their choice whether they want to start that or not. Side effects are usually observed during the first month or two from commencing the therapy, and these side effects may be caused by both estrogen as well as progesterone, and usually settles by the third month of the treatment. So you exactly have to explain like that to increase the confidence of the patient for the use of this medicine. If you only criticize this medicine, if you only show the negative things about the medicine, that lady will never accept it. And these are some of the side effects: nausea and tenderness of the breast in about 10% of the case, weight gain and fluid retention. So she may gain weight after the use of these hormones. So because of this single point, many of the ladies, they don't want to use the medicine because they don't want to gain any weight. Headache, estrogen side effect, but this headache is not very severe at all. Bloated sensation associated with progesterone, which slow the bowel action. Remember, progesterone or progesterone is a relaxing type of hormone. So it relaxes the bowel smooth muscle. So there is decreased type of peristaltic movement. So gas, okay, may remain there inside the bowel. That gives rise to bloated type of sensation. Leg cramp and estrogen side effect. Slight increased risk of cholelithiasis. Again, effect of estrogen. Glucose tolerance may be impaired. Okay, glucose tolerance may be impaired. So over a period of time, she may develop frank glucose tolerance or even diabetes. Very occasionally, there may be a marked increase in blood pressure, even hypertension. This type of cases have been reported. Remember, see that fluid retention. is associated with hypertension over a period of time. These are considered some of the side effects. Now let's move on. Now, what are the complication? These are not considered as a side effect. These are considered as a complication itself because they are more serious type of the problem. So unopposed estrogen replacement therapy is associated with an increased incidence of endometrial hyperplasia and endometrial carcinoma. By this time, all of the students know about this. And okay, they have also have increased incidence of abnormal bleeding pattern. This is known as uh, intermenstrual bleeding or some sort of breakthrough bleeding. These are quite common. There is evidence of an increased risk of breast cancer if there has been more than 5 years of postmenopausal hormone replacement therapy. This is also associated with estrogen, which is there. So even if we use this, not so long, probably 2 to 3 years, and by the time the lady is, settled into the postmenopausal life, we can decrease it or we can stop it. There is a demonstrable increased risk of thrombosis, though very slight, with modern hormone replacement therapy formulation. This is again a problem of estrogen. Now, at last, what are the contraindications? In this situation, hormone replacement therapy should not be used. One of that is history of breast cancer. The risk of breast cancer recurrence and of new breast cancer may be increased in hormone replacement therapy. So patients who are taking hormone replacement therapy should be counseled about the increased risk of breast cancer after 4 to 5 years of use. Very, very important point. Specifically, if there is a family history of breast cancer, which is quite common, one of the important risk factor for breast cancer is family history. The lady may be carrying the gene, so during that situation, it should not be used. History or non-high risk of venous or arterial thromboembolic disease, stroke, and cardiovascular disease also. These hormone replacement therapies are contraindicated. Okay, contraindicated. Now, this is a little bit of a confusing thing for you. Atherosclerosis risk is decreased by estrogen, but the chance of thromboembolism is higher. Okay, the chance of thromboembolism is higher, and both of them are important risk factor for arterial or venous disorders. So we need to be careful. We need to rule out whether there is any thromboembolic phenomena going on. Is there any higher risk or not? Uncontrolled hypertension, we don't go for this hormone replacement therapy because they clearly increase the blood pressure. History of endometrial or ovarian cancer also, contraindication. You don't want to go for that. And these are the relative contraindication. Abnormal uterine bleeding or AUB, abnormal liver function, as well as migraine. Okay, migraine. I have to correct the spelling here. GRAINE, migraine. So in migraine also, hormone replacement therapy can exacerbate the situation. Can you tell me what is migraine, by the way? What is that? Anyone?
The migraine is pain, sir, mainly on the one side of that.
One side, head pain.
Okay, migraine is a headache. Very good. It's a type of headache. There are 3 important types of primary headache we have: migraine, cluster headache, and tension headache. Migraine is very, very common in general population. It is more common in female. It runs inside the family. It has a family history. And during migraine, the pain occurs on the head, which may last from 4 to 36 hours. From 4 hours till 36 hours, the pain continuously there for 3 days sometimes in the patient. They may have nausea or vomiting. After vomiting, the pain gets better. They are, they don't want light, okay, or they are irritated by the sun exposure. So they don't want to walk outside in the sun during this headache. They don't want, excessive noise. They don't like it. This is known as photophobia and phonophobia. These are typical features of migraine. So in migraine, different types of treatments are given.